Welcome everyone, and thank you for joining us for our presentation titled Cancer in the Era of COVID-19, Public Health Perspectives. It's my pleasure to introduce you to our featured speaker, Dr. Tala Al-Rousan. Dr. Al-Rousan is an internal medicine physician and epidemiologist who designs and develops large-scale population studies to understand and evaluate public health interventions. She is currently an assistant professor at the Herbert Wertheim School of Public Health and Human Longevity at the University of California, San Diego. For a complete biography of our speaker, please visit the tab at the top of your screen. If you have any questions that arise during the presentation, we encourage you to submit it in the Q&A box. Our speaker will address your questions following this presentation. Please join me in welcoming Dr. Tala Al-Rousan. I will now turn the presentation over to her. Welcome.
Thank you so much, Susie. Thank you for being here today. My name is Tala Al-Rousan. I will be discussing cancer in the era of COVID-19 from a public health perspective. My disclosure, the support for this program is provided by Abbott, and the information I'm presenting here is based on my own interpretation of the evidence and clinical experience. So just a little refresher to remind us all of coronaviruses and the novel 2019 coronavirus pandemic. So coronaviruses are important human and animal pathogens, as we all know. They've been here with us and lived on this planet for a long time and have caused some other pandemics and outbreaks, such as the Spanish flu in 1918. In 2019, a novel coronavirus was identified and has caused the pandemic that we know of today, which is COVID-19 pandemic. The virus that is causing this pandemic is designated as severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2. The problem with this virus is that it's highly contagious, and vaccines do not seem to cause long-lasting immunity for it. Just like the flu virus, we are yet to understand how to develop long-lasting immunity for it. Also, there are disparities in incidence and mortality rates that make control very difficult. Up until today, there are more than 900,000 people that have died due to COVID-19 worldwide. And we believe that it will be, as they say, a marathon trying to combat this pandemic rather than an easy task. So the pandemic has impacted all areas of daily life as we know it, including medical care. So the delivery care model has been impacted, especially for cancer patients in many ways. There are competing risks as we know it. Cancer patients are immunocompromised, which puts them at great risk for contracting the virus and for dying from it. There are interruptions to care for patients with cancer, as well as the lack of resources. So many people now have been reshuffling resources in a way that has impacted cancer patients negatively, and we'll be discussing that in more depth. As they say, there is no one-size-that-fits-all approach to delivering care. So for cancer patients, as we know it, we're talking about personalized medicine. We're talking about different case-by-case type of care that is impacted, of course, by all this interruption to care, as well as the problem of having no international guidelines. Of course, because it's a new pandemic, we are still struggling to really have a centralized approach to dealing with it when it comes to cancer patients. So now we're seeing a lot of drive-through blood draw injections. We're seeing some staff travel restrictions, social distancing in waiting rooms and work areas, new screening procedures and laws when it comes to cancer patients who are in active treatment and those who are screening for cancer. And of course, we're seeing the major shift to telemedicine and virtual check-ins. So patients with cancers, as we said, are one of the groups that are most impacted by the pandemic for two main reasons. Number one is that they are immunocompromised, so there is some status of systematic immunosuppressive state that these patients have. And number two, the requirement for frequent admission to the hospital. which of course increases the risk of getting the virus. As we know, or as we may expect, incident cancer diagnoses may increase during or after the pandemic due to halted screening. So of course, screening is being impacted the most during this pandemic, one would think. And again, we will be discussing this in today's talk in more depth. But this is a time for us to think ahead and develop evidence-based guidelines for management. The big question in research right now is that, does cancer increase one's risk of contracting coronavirus and getting COVID, or is it the other way around? Patients who get COVID are at increased risk of developing cancer. And I think it's a mixture of both, really. So both sides of the story could be true, and there's a lot of research and resources now heading into that direction to really try to answer these questions. So we know that cancer increases risk for COVID through immunodeficiency. So cancer patients are immunocompromised usually. Certain cancers like lung cancer, there is already a pre-damaged lung. So we're expecting COVID to present itself in a more severe form in lung cancer patients, as well as, of course, the comorbidities that cancer patients usually have, such as hypertension, diabetes. And of course, the frequent hospitalization of cancer patients increases the risk of contracting the virus while being hospitalized. And also a big question remains is that what happens if someone gets COVID? And now, looking at different disease models, we don't understand on the long term, if someone contracted the virus, would they have some lingering effect? For example, some research now is showing that COVID might have some, might cause some brain damage. We know now that there is an increased inflammation, persisting chronic inflammation status due to COVID. We know that the virus enters the cell through the ACE receptors or the angiotensin converting enzyme receptors. So it really does affect the biochemistry of cells. So could that promote oncogenic transformation? Could cells become more cancerous at a higher rate or at an earlier stage? So that's a question that is out there for researchers, and now they're actively seeking answers for it. So what's the global burden of cancer? We know now that almost 18 million people, or a little over 18 million people in the world have cancer. And the projections are that in 2040, more than 27 million people will have cancer. So that's a big jump. And cancer accounts for 8.8 million deaths annually. 70% of these deaths happen and occur in low and middle income countries. So in the grand scheme of things, 1 in 5 men and 1 in 6 women have cancer or have had cancer at some point in their life. And that 1 in 8 men and 1 in 11 women die of cancer worldwide. So it's a huge global burden. This burden, as we said, is expected to grow, and it's even expected to grow exponentially at a higher pace in less developed countries than in more developed countries. So Asia, we know, accounts nearly for half of all cancer cases now, and more than half of cancer deaths worldwide. And we believe that Asia and Africa have higher proportion of cancer deaths compared with their incidence, meaning that they have higher frequency of cancer types that have poorer prognosis, as well as limited diagnosis, screening, and treatment capabilities, which makes these countries really at higher risk of developing a larger global burden of cancer. So why are we expecting more people to be diagnosed with cancer? For 2 reasons. Reason number 1 is the population growth. So we know that the population is growing worldwide. Reason number 2 is they're getting older, right? So aging, also global aging, is a major issue. As well as the risk factors, of course. So here in the UK, for example, they've done research modeling and predicting the numbers of people that will have cancer in 2035, and cancers due to risk factor changes only. So by looking at numbers only of people, there's a large number of people that will get cancer because of population growth, but also because of risk factors and how our life is changing, technology, how we're having more sedentary lifestyles, obesity, that all is also contributing to this picture of having larger prevalence rates and incidence rates of cancer. Also, there are certain types of cancer that are clearly underfunded in terms of research, like lung cancer. So we know that lung cancer accounts for 13% of new cancer diagnoses. Almost a quarter of all cancer deaths are due to lung cancer. And the survival beyond 5 years is really low when it comes to lung cancer. However, when you think about funding or look at the funding and the numbers, only 6% of federal research dollars are designated to look at lung cancer and research lung cancer. How is this pandemic affecting cancer research? So a survey by the American Cancer Society surveyed about 488 funded cancer researchers here in the United States, and it showed reduced cancer research capacity and efficiency. So most of them are not being able to resume their research, of course, due to lockdowns and due to underfunding and other resources. And again, we'll talk about this a little more later on. We also know that pre-pandemic, there were clear disparities in cancer screening. So for example, whites are 32% more likely to be up to date with cancer screening such as colorectal cancer than American Indians or Alaskan Natives. We know that women in the highest income brackets are more likely to be up to date with cervical cancer or breast cancer screening than women in the lower income. We know that women who have private health insurance are more than twice as likely to be up to date with screening too. So these disparities exist. They exist on a global level. Socioeconomic status, where you live, so many things impact how much you know about cancer and how often you screen and how you receive your care. What about cancer in numbers during the pandemic? So in England, they did this national population-based modeling study looking at different cancer prevalence rates and incidence rates. They looked at breast cancer, lung cancer, esophageal cancers. And by looking at the wait time in emergency presentation and how much care these cancer patients are receiving, they have seen more deaths of cancer. Of course, again, because people are not screening, they're delaying care, there's an interruption to care. So there was 7 to 10% more deaths in breast cancer, 15 to 16% more deaths in lung cancer, and 4 to 5.3 in esophageal cancer. So again, this pandemic is really impacting cancer patients disproportionately. And recently, only last month, there was a study by the JAMA, by the Journal of the American Medical Association, that showed that they studied more than 200,000 cancer patients. They looked at pre-pandemic and current incidence rates of many types of cancer. And this study in particular has shown significant decline in newly identified cancers. So unlike what one would predict, we are not able to pick up these numbers. That's why we are seeing lower incidence rates of cancer during the pandemic. Findings were also similar to studies from the Netherlands Cancer Registry, which is a national cancer registry as well, and very representative of the people of Netherlands, as well as the UK, where one study has shown 75% decline in referrals for suspected cancer since COVID restrictions were implemented. So this is the JAMA study where people have looked at numbers, researchers have looked at numbers between March and April. As you can see, the newly identified patients numbers have decreased exponentially for almost all these types of cancers since the pandemic has hit. So how does one provide safe care for patients during these challenging times? The American Society of Cancer, Clinical Oncology, and CDC have offered some guidance through guidelines that they have come together and put together. These guidelines offer guidance on general healthcare facility and healthcare professional guidance, clinical care guidance, home care guidance, and what do we do to high-risk subpopulation guidance, so certain types of cancers. It seems like in general, any clinic visit that can be postponed is being postponed. So routine surveillance visits like mammograms, colonoscopy are being postponed now due to the lockdown and the mitigation and containment efforts that we're using for this pandemic. Screening clinics are being developed to allow for patients with symptoms to be evaluated and tested before entering the facility. So the goal is if there is a COVID patient, you need not to get them inside the facility. There are concerns about the halt in national screening programs in most countries. And we know Japan, for example, has a national cancer screening program that is excellent. Even that is being halted now and stopped before because of the pandemic. And this has impact on future cancer mortality, as I said. So one should think of these numbers and what happens since people are not being able to go and screen for the cancers. So the backlog of patients with symptoms will happen once we are into this pandemic and we start to loosen the lockdown measures that we're taking. And systems have to be prepared for that. Now, for the anti-cancer treatments also, there is, of course, delaying the elective surgeries that people are having, such as reconstructive breast surgery, etc. Those are all being delayed. Usually they're resumed if infection rates are downward for at least 2 weeks, and if resources can be looked at in a way that a hospital now feels okay with returning patients with elective surgeries. Also, scheduling of cases and prioritization of cases is usually managed by all stakeholders. So different, surgeons and doctors who are internal medicine doctors, they all have to agree to return this patient for elective surgeries. For radiation therapy, randomized clinical trials now support deferring also radiation therapy across a multitude of cancers. And they tend to place systemic therapy first in the treatment sequence. Overall, for chemo, immunotherapy, and systematic, there is no direct evidence to support changing or withholding chemotherapy or immunotherapy. However, it's case-by-case basis, and of course, it depends on the provider and the place where someone is receiving their treatment. So, of course, Al-Shamsi al and some other researchers have come together under an international collaboration group to put some guidelines, such as the one we're seeing in front of us, that can guide our decisions to therapy during these times. Also, it's worth mentioning that this shift of telehealth is impacting patients a lot, especially cancer patients. So now providers are thinking of how to deal with patients through the video and phone calls, what kind of questions they should expect, the notion of empathy and how do you do that virtually. These are all things that are new and being presented to us by this pandemic. We also know that mental health is a big aspect of cancer patients and cancer care. We know that patients usually with cancer present with stress, depression, anxiety, insomnia, denial, anger, fear. And there are studies now surveying patients with cancer on how do you feel during these COVID times or the COVID pandemic. More than half are worried, of course, 45% are understanding, 42% are anxious, many are stressed, 33%, and 22% are depressed. We also have to not ignore the mental health toll on providers and caregivers, family caregivers, providers, physicians are complaining from burnout, isolation, worry about own health during COVID times and contracting the virus, as well as competing demands at work. Many doctors and providers are being pulled into COVID service or caring for COVID patients. Of course, that comes with its own mental health challenges. Some of the coping mechanisms or suggested solutions now are to create coping mechanisms, groups, communication guide, again, like the one we've seen before, that where providers can learn more on how to navigate care using telehealth, as well as supportive measures that could be offered to patients. So this is a survey that was done by the Cancer Action Network, American Cancer Society, where they surveyed more than 3,000 cancer patients and survivors on the types of insurance they have, as well as the burden that COVID-19 is presenting them with. So 49% of all patients surveyed had employer-provided insurance, 32% had Medicare, 7% were privately insured, 4% were on Medicaid, and 7% had no coverage at all. And they asked these patients whether they were worried that the financial impact of COVID-19 will cause and will make it harder for them to afford care as a cancer survivor. Of course, the lower the income, the more likely you are to be worried about that, about receiving care as a cancer survivor during COVID time, but also those who were in the high income as well were worried. So 21%, which is almost a quarter of all patients who are in the high income category, were also worried about receiving less care as a cancer survivor due to the pandemic. Also, the effects of COVID-19 on healthcare were obvious in terms of almost 27% of respondents who were in active treatment for cancer, their care or treatment was delayed or canceled, versus 24% of those who could be cancer survivors or in between. So it did impact everyone, those who are in active treatment and those who are survivors. A cross-sectional study on COVID infection mortality rate from 396 counties in the United States, from 7 states, looked at COVID in cancer patients. And those who were African-American, older, and had increased risk of ICU stay and intubation were more likely to contract COVID-19. So cancer patients, again, cancer disparities are obvious. The pandemic is shedding the light on these disparities, which is very important for us to kind of have these conversations on, and should guide the way we think about health and well-being in general for cancer patients. Also, socioeconomic factors, as we mentioned before, as well as other social determinants of health, play a major role in explaining these disparities. So where you live, what kind of job you have, are you an essential worker that you cannot stay at home? All of these things explain much of what we are seeing due to the pandemic in cancer patients. So bringing such data to the surface will help us understand these structural issues and understand also who to screen, how to reach these hard-to-reach populations and these minority populations, etc. So this is the time to be really thinking about this, even to tackle cancer and its disparities. So equitable cancer care is really something that I think should be completely emphasized due to this pandemic and will be how we think about cancer care moving forward. So non-communicable diseases prevention and control should be a global priority, although this pandemic is presenting itself through an infectious disease. Non-communicable disease remain a big killer worldwide. And if we do not address that, then any virus and any future pandemic could really cause what we're seeing right now and the loss of lives that we are seeing right now. Universal healthcare should be a human right and should be rethought in every single country. And I take the quote of Princess Dina Married of Jordan, who is also the president-elect of the Union for International Cancer Control. Her vision is really that we cannot combat cancer unless we talk about universal healthcare and about making non-communicable disease prevention control a global priority. Also, improving breast cancer survival is a big thing, especially in the less developed world. We need to talk more and invest more in breast cancer survival. And we need to share the global responsibility to support certain groups, such as refugees with cancer and hard-to-reach populations and conflict zones. All of those are contributing to the cancer disparities that we're seeing right now due to COVID. So what if a patient who has cancer is infected with COVID? What are the numbers like? What is the picture like? Incidence in cancer patients was higher in studies from China, about 3 times higher, and from Spain, about 4 times higher. However, also studies from Europe have suggested similar or lower incidence of COVID-19 in cancer patients when compared to the general population. So the evidence on that is mixed, and still we are yet to capture that in more studies and more statistics as we head into the new year. Prevalence rates also varied in studies. So if infected, likelihood of severe illness and death from COVID-19 is higher, and that's something we all agreed about. We talked about how cancer could increase your risk of dying from COVID-19 due to the systemic immunocompromised status that patients have, but also the chronic persistent inflammation that is believed to happen due to the disease, the COVID disease. A meta-analysis study included 32 international studies and looked at 46,000 patients or more, showed an increased all-cause mortality in cancer patients due to COVID, as well as increased ICU admissions. And it is believed that 1% of all patients with cancer who has COVID have had, 1% of all patients who have COVID now have had a history of cancer before. So this is the socio-ecological model, which is really the basics of public health science and research. We don't think of health as only individual factors, but rather it's the interpersonal, organizational, community, and public policy layers that all interplay in dictating one's health and prognosis, especially when it comes to cancer. So while certain cancers like lung and hematologic cancers are associated with increased risk of mortality from COVID-19, the social determinants of health play a major role in prognosis from COVID-19. And that's why we're seeing higher mortality rates in, as we said, patients from racial and ethnic minorities, those who live in rural areas compared to those who live in suburban areas. The impact of whether the cancer is active and whether the patient is currently receiving treatment also remains unknown at this point. So some research needs to be done in that area. Now, what's the effect of cancer treatment in COVID-19 severity? And a recent study also has been looking at more than 900 patients from the US, Canada, and Spain. It showed no higher 30-day mortality rates in cancer patients who had COVID-19. So this is, again, some unlike what we've seen in the previous studies. This study is saying that there is no higher mortality rates in cancer patients who have COVID. Also, a similar study from the UK has showed similar results. However, as we know, the type of cancer and the treatment you're receiving may influence the risk. There was a study that retrospectively looked at symptomatic COVID-19 patients who were treated with immune checkpoint inhibitors. They had threefold the risk of hospitalization and severe COVID presentation. However, cytotoxic chemotherapy did not show a significant association. So again, these are studies that could inform our guidelines on how to manage cancer patients. There are, again, some challenging types of cancers like solid tumors, hematologic malignancies, and COVID-19. Together with, if someone has these kind of tumors and has COVID-19, the prognosis is believed to be worse due to older age, comorbidities, and immunocompromised status. Another challenge in these patients are that some of them are under cytoreductive treatment or immunotherapy. So patients with lung cancer or metastatic lesions, for example, they might present with symptoms similar to COVID-19, which makes it difficult to really manage these patients. Also, certain type of tumors, like brain tumors and people who have brain cancers, they often have to travel to hospitals. Hospitals are more advanced, they offer better care and more advanced care. So this all impacts their quality of life in terms of the fear of facing this pandemic with an immune system that is significantly weakened by the disease, by the treatment as well, steroid, radiotherapy, or chemotherapy. So what's happening when it comes to testing and cancer patients? So we usually are doing priority testing for cancer patients who either present with symptoms or are exposed to a COVID positive person. However, if a person has no symptoms and have not been exposed to someone who had COVID, it really varies across institutions. So for cancer patients with lower respiratory symptoms or signs, those who have fever, cough, dyspnea, we like to proceed with nucleic acid, usually amplification testing. Testing would be preferred prior to highly immunosuppressive treatments. So at some institutions, testing of asymptomatic patients prior to initiating anti-cancer treatment is limited to those who have blood cancers or hematologic malignancies. Many places offer testing to all lung cancer patients. And again, it varies from one place to the other, from one country to the other, based on test availability and resource availability and what the team thinks is best and should be done and how resources should be allocated. So this is really to discuss more about testing as we know it. There are two types of testing. Testing that is viral RNA detection and viral antibody response detection. And both of those testing techniques have their own limitations. We know that a return to chemotherapy criteria could be entertained once reliable antibody testing and viral titers are developed. So really false positives and false negatives and how sensitive the testing is could dictate whether we go back to chemotherapy or not. As testing becomes more widely available, it may be reasonable to test all asymptomatic patients who will be receiving immunosuppressive anti-cancer therapy or who are believed to otherwise be at risk for serious complications from COVID-19. And the results of such testing can really inform decisions about delaying cancer therapy versus not. Also, testing is very important as we think about vaccines in the future. So after we develop a vaccine, antibody testing may aid in vaccinating those with low titer of protective antibodies. So really, when you think of how cancer patients present themselves, they're either asymptomatic or symptomatic carriers of COVID-19. So it's very important to be developing testing that is highly sensitive and specific and can give us the accurate answers so that we could proceed with our decisions for therapy and what's next. Patients with B-cell malignancies like lymphoma or multiple myeloma, chronic lymphocytic leukemia, they will likely have distinct antibody responses. So those patients may require a specialized pathway and specialized testing techniques. So that's also an area that is very important to be researching and doing. Patients with a known exposure need to be tested, of course, quarantined and closely followed up. Now, we know that due to the restrictions and the lockdown and the reallocation of resources, clinical trials, many cancer clinical trials are being halted. We also know that now COVID is making us rethink how we do discoveries, right? So COVID-19 infection has led to shortening of traditional regulatory timelines. This experience should stimulate similar urgency in the way future cancer research is conducted. So hopefully we'll learn from this pandemic how to get things on the market and to patients who need it faster. Now, what are the lessons, the big lessons that this pandemic is teaching us? First of all, invest in public health. It's very hard to invest in something that you don't see in front of you. It's very hard to prevent things. That's why we are having difficulty screening for cancers and asking people to screen. But hopefully this pandemic is teaching us that even if you don't see something, that doesn't mean it's not going to happen. Also, underserved population often suffer from chronic comorbidities. So again, those are and should be our target populations for increased screening efforts, prevention research, genetic research. These populations have less access to healthcare, usually for chronic conditions, including cancer. And sometimes they don't have the ability to shelter in place. As we said, most of them are essential workers. So all of these factors need to be addressed. Family members at the bedside also is something very important. And we're learning now that due to COVID, a lot of cancer patients, unfortunately, are dying without any family members on their bedside, which is really a big problem. Also, ICU nurses, usually there's shortage of staff. So now we need to invest more in this field and in this area. Of course, we need to diversify our clinical trials more. So providing a valid and vetted communication channel to get more minority groups, more women into our clinical trials are extremely important. So communicating the importance of clinical research is extremely important. And separating signal from noise, the opportunities that having all of this information creates for data and technology to provide meaningful and large-scale impact are really large. And I think this pandemic is helping us rethink how we can advance cancer therapies and cancer technologies and innovation in cancer care, instead of just looking at the tough picture of losing a lot of patients due to cancer due to halted screening. So again, really looking into the opportunities is something we should be thinking about. Now, the greatest challenge is how do we help people who are afraid to seek care to begin with? Most of our public health messaging regarding COVID has focused on mitigation and containment efforts, so social distancing, washing hands, PPE. We also need to really think about, whether you have COVID or not, we are still here for you. So as systems for cancer patients, we need to really be rethinking how, despite all what's happening, how do we manage these risk versus benefit. I think a great opportunity for us during this pandemic is to rethink breast cancer care. So the falling costs of sequencing DNA have created an opportunity for us to explore new approaches to screening, which incorporate genetic information. And really, it's important now to revisit that and think of clinical trials that can introduce new therapies and incorporate genetic information. As the tools and methods for screening improve, doctors can start to do less screening for people who are at lower risk. This is the way that the field is going to evolve. So we need to put resources to the people who need them the most. I think MammaPrint assay is really an interesting technology. So there was a recent research that was presented at the 2020 American Association for Cancer Research virtual meeting that happened a few months ago. And it highlighted how MammaPrint assay may effectively guide chemotherapy decisions during the COVID-19 pandemic. So these technologies could help us really make decisions on to move forward or not. So using MammaPrint in hormone receptor positive patients with up to 3 nodes in whom chemotherapy is considered, the treatment can be limited, allowing safe de-escalation of therapy without increased cancer-specific mortality from COVID. Now, eradicating cancer is a big dream, and it's what we all work for in the cancer community, and it lies in both fields, I think. The biggest opportunity is to work on prevention. So prevention research is key. Cancers do not have a single cause, as we know, and much of the work could be invested in prevention, as well as genetics research, which is really the holy grail, would be a test that could pick up the earliest warning signs or signals of cancer. A popular vision would be to use such tests in the general population. So hopefully the future would be a genetic test that could be applied to everyone in the population. So in summary, the data is clear in showing that severe illness from COVID is higher among adult patients with lung cancer and certain types of cancer. The data is mixed on other types of cancer. However, more research is emerging now, which is really great. And the data on whether recent cancer therapy impacts severity are mixed. So the most important risk factor for severe disease usually are things that have nothing to do with cancer, such as social determinants of health, how old you are, where you live, how many comorbidities you have. Of course, the psychological impact of this pandemic on cancer patients and providers and caregivers is huge. Communication is key. So again, in the cancer world and cancer research, it's very important for us to all come and sit together and talk, such as this summit that hopefully will host some of the most brilliant minds in the world to come together and share their views on the future now that this pandemic has been affecting every aspect of life. Innovations in testing and screening for both cancer and COVID should be hand in hand. So we should not wait on cancer. As they say, cancer does not wait, even if there's a pandemic. So yes, this is again a slide for how every aspect of the cancer care model and every stakeholder should come together and try their best to not let this pandemic impact how we research cancer, how we provide new drugs and new therapies, or how we think of innovations in cancer. If there are take-home messages that I would like you to have from this talk, is that the balancing of risks of delaying cancer versus not, or versus the risk of COVID-19 exposure are challenging. The guidelines are changing, It is a rapidly changing situation. Cancer research should be prioritized and funded and should not be halted due to the pandemic. Clinicians should proactively discuss goals of care and advanced care planning, including advanced directives, especially for those with advanced cancer who are at an elevated risk for COVID-19, such as lung cancer patients. Finally, this is a picture of Mildred Geraldine, who was recently featured in the news here in the United States. Mildred has survived the 1918 Spanish flu, COVID-19, and cancer. And I know, although I painted a little bit of a tough image now by showing these statistics of the global cancer burden and how this pandemic could be negatively impacting cancer research and advancements, I want us all to be thinking like Mildred. It wasn't bad, and we will get through this, and hopefully, the pandemic will actually be the reset button that will help us innovate and help us all come together as a global community and tackle the global burden of cancer. Finally, I'd like to acknowledge Princess Dina, who is the president of the Union for International Cancer Control, the Global Cancer Oncology, the European Society for Medical Oncology, our colleagues at the International Agency for Research on Cancer, as well as my colleagues at the American Society for Clinical Oncology. These are my references, and thank you so much for attending this talk.
Thank you, Dr. Al-Rousan, for that outstanding presentation. We will now move into the live Q&A portion of the presentation. As a reminder, please submit your questions via the Q&A box. So let's take a look. I see some questions already in our Q&A. Dr. Al-Rousan, in Africa, there are no clear guidelines on what to do when a patient with cancer on chemotherapy develops a fever. What would be your advice to that?
Thank you so much for that great question. And hello to my colleagues in Africa. It's a great question. We cannot ignore the possibility of a cancer patient developing neutropenic fever, malaria, typhoid. What if someone presents with those and he has cancer? Should we call the overstretched and under-resourced COVID-19 team? The paucity of personal protective equipment and gear and on-site testing kits for patients and healthcare staff on the continent of Africa is a major flaw in delivering life-saving care for cancer patients. I think the availability of logistics, which are greatly inadequate, institutional guidelines, and the country-specific COVID-19 case burden will dictate actions. So really, Africa is a large continent, and each country is dealing with a pandemic very differently. I know in West Africa, for example, the COVID-19 protocols are defined by individual institutions. However, in South Africa, who are now dealing with local epidemics, small local epidemics of concern is HIV, and TB, which includes approximately 8 million people who live with HIV in South Africa. So far, cancer care is impacted by competing risks, as we said. Oncologists in Africa, despite the absence of a centralized guideline or plan, they are actually pragmatically safeguarding their patients and workforce. It's a difficult task. There is no perfect answer for this. However, I feel despite the scarcity of resources, they're doing a great job.
Thank you. And Dr. Al-Rousan, you've touched in your talk on screening. In regards to thinking about COVID testing, how important, in your opinion, is screening to cancer? And this is a two-part question. How would screening change the cancer picture in the future?
That's a great question. As we mentioned during this talk, screening has been halted due to the pandemic, and we feel that screening is extremely important for cancer. As you know, we pick up cancer at an earlier stage. We reallocate resources in the way they should be allocated. So they go to patients who really need to be treated for cancer. So the whole idea is that screening should be invested in more and more. And this pandemic is showing that actually, despite the fact that we're halting screening, patients are being impacted, and we will see this backlog in the future. So we will see more cancer patients presenting because of these lack of screening. So for example, for something like colorectal cancer, screening could really impact survival and could impact which stage you pick up a cancer. So screening is something that should be invested in heavily worldwide, whether there is a pandemic or not. From my own perspective, screening should be always prioritized.
Thank you. And do you see cancer testing moving into home testing using testing kits, just like COVID-19 testing changed in such a short period of time?
For sure. And I think during this talk, that was the main point that we're trying to emphasize. So again, we're seeing testing as an innovative testing techniques that could be genetic, that could pick up signals early on, and that could be distributed to the entire population. So the future should look something like this if we want to really tackle the global burden of cancer. Testing should be widely available for everyone. Testing should be advanced in the sense that it could pick up signals very early on. It could pick up transformation and genetic material of cells early on.
Thank you. So I would guess then you see cancer testing in the future changing to home testing.
Mm-hmm. That's exactly right.
Thank you so much. And we have time for one more question. It seems from your talk that cancer research may face a recession because of the pandemic. Can you elaborate on that and what should be done to avoid that from happening?
Thank you for that question. Yes, the exponentially increasing numbers of articles published since February 2020 related to cancer and the COVID-19 pandemic have really focused much on risk reduction and management of cancer patients during this outbreak, as well as really characterizing cancer patients. So again, epidemiologically talking about statistics and which cancer patients suffer the most, and et cetera. So really, we are mostly thinking in a myopic way at this point, just really trying to think about COVID-19 and cancer patients. However, I think the priority of oncology researchers during this pandemic should not be only on COVID-19 among cancer patients. This is something we're seeing in other fields of research as well. We call it the COVIDization of research. At this point, really, I understand that most governments are trying to secure their citizens, and they want to make sure that the loss of lives and the numbers are not high up of those who die of COVID. However, the load of research and publications and new trials in oncology should be to, motivate cancer researchers to get back on track, get back to work once the restrictions are loosened, and to keep innovating and to keep their new trials, cancer in general, working and going on. Because again, cancer cannot wait.
Very true. Thank you again, Dr. Al-Rousan, for this incredible presentation and for your important research. Thank you for the audience for your outstanding questions. We hope you found today's presentation informative and insightful. This presentation will be available on demand viewing, and don't miss out on the other valuable presentations on our agenda. Visit the agenda tab in the auditorium for the full listing. Thank you again for your participation. Until next time, be safe, stay healthy, take care, bye-bye.